We often hear people say, she had bone cancer. But what do they really mean? Often they mean that their friend or loved one had metastatic disease to the bone. True bone cancer is actually quite rare. Many people who have epithelial cancers will develop metastatic disease to the bone. But there are some tumours that arise specifically in the bone. Benign bone tumours, relatively common. We'll discuss a few of the most common of these. And then the malignant tumours, osteosarcoma, which produces malignant bony matrix, and chondrosarcoma, that produces malignant chondroid matrix. And then finally, multiple myeloma, a disease of plasma cells that arises in the bone marrow. So here are some key concepts about bone tumours. Metastatic malignancy is the most common malignancy of bone, and multiple myeloma that arises from the bone marrow is more common than osteosarcoma. Osteosarcoma is a relatively rare, though feared tumour and has a double peak in teenagers and in the elderly. How might we suspect that a person has metastatic disease rather than primary bone tumours? Well, the first is that it's multifocal. The second is the position. So metastatic disease usually metastasizes to the marrow, particularly in the axial skeleton and in around the proximal long bones. In the picture to the right, we can see the bright pink bony trabeculae, and in between, where there should be normal fatty bone marrow, it's been replaced by a really pleomorphic looking tumour. This is what metastatic bone disease looks like. Particular cancers have a particular propensity to metastasize to the bone, and generally they're all tumours that arise from epithelial cells. Prostate, breast, kidney, lung, thyroid and colon. The only exception is malignant melanoma, which also tends to metastasize to the bone. You'll notice there's a bit of an overlap here with the tumours that metastasize to the brain. Yay, you only have to learn one list of things that metastasize to both bone and brain. Let's move on to thinking about primary bone tumours. They occur predominantly in the first 3 decades of life because this is when there is greatest skeletal growth. Did you know that large dogs have a much higher risk of getting primary bone tumours than small dogs? It's all to do with skeletal growth activity. Osteosarcoma occurs predominantly around the knee. The distal femur and proximal tibia have the highest growth rate of bones in the body. All bone tumours have a specific radiographic appearance that can help us tell whether it's benign or malignant. This is used in combination with the clinical history and a bone biopsy if necessary to make the diagnosis. Let's think about osteochondroma for a while. Osteochondroma, also known as exostosis, is one of the most common benign bone lesions. It happens near the metaphysis of bones, particularly around the knee. They're slow growing and can be painful, but always benign. They're caused by a sideways displacement of the growth plate, and thus a new micro bit of bone starts growing off the side of the usual bone. Most of them are solitary, but sometimes people have them as part of an autosomal dominant hereditary exostosis syndrome. Another benign tumour is the benign cartilaginous tumour, chondroma, or enchondroma if it occurs inside bones. An enchondroma occurs within the medullary cavity, particularly when the tubular bones of hands and feet, whereas a chondroma occurs on the surface of bones. Again, there is a genetic disease, Ollier's disease, where these can become multiple and can undergo malignant transformation. A third benign tumour is giant cell tumour of bone. It is benign but can be locally aggressive and recur if it's curetted out. It can occur around the knee like other bone tumours quite commonly, but can occur in a large number of other places. Again, it occurs around the metaphysis and epiphysis. The picture on the right here shows the typical microscopic appearance of a dark brown jellyish kind of mass in the bone. Microscopically, we look down the microscope and see it's made up of mononuclear cells, that's that background of cells, with really characteristic osteoclast-like giant cells in it, and that's where it gets its name. Osteosarcoma is a dread disease. The picture here shows a child with an obvious large bony mass around the shoulder. This is a real red flag and a very late presentation, but always be aware that persistent bone pain in children should not be written off. An osteosarcoma must be actively eliminated from the diagnosis. So what is osteosarcoma? Well, it's a sarcoma, a malignant tumour, and osteo because it produces bone matrix. It's the most common primary bony tumour, i.e. not including myeloma, and it occurs in a bimodal age distribution, with most occurring in young people when their bones are maximally growing, but also in older people with an underlying disorder of bone, particularly Paget's disease, which makes the bone proliferate. 50% of them occur around the knee, and the rest of them occur mostly in long bones in areas of fast growth. So what are the risk factors for osteosarcoma? The people with the highest risk of osteosarcoma have a genetic abnormality, such as Ollier's disease, or people who carry the retinoblastoma gene. This also increases the risk of osteosarcoma as well as eye tumours. Or, for example, people who have an abnormality in the p53 gene, the so-called guardian of the genome, which is in charge of apoptosis. If this isn't working, then young people get osteosarcoma. The next category is people of moderate risk, people with Paget's disease who've had radiation to bones or who have multiple osteochondromas. And then there's people who have an increased but low risk, such as bone infarct, chronic osteomyelitis, or metallic implants, as all these can increase bony proliferation. This is what osteosarcoma looks like in an advanced case. It occupies the central part of the bone close to a metaphysis and then has burst out and is forming this large mass overlying the periosteum. About 20% of people with osteosarcoma will have pulmonary metastases at diagnosis. It is a tumour that spreads hematogenously, primarily to the lung as a first stop. Combination treatment with radiochemotherapy and sometimes amputation will lead to a long-term survival in about 60% of people. Let's move on to thinking about chondrosarcoma. There are many ways that we can contrast chondrosarcoma with osteosarcoma. They're both sarcomas arising from malignant mesenchyme, but they have a different distribution and a very different X-ray look. You can see here this tumour is arising from the pelvis and has a kind of soap bubbly, flocculent look. This tells us that it's a chondrosarcoma. So a chondrosarcoma is a malignant tumour producing neoplastic cartilage. It's the second most common malignant matrix producing tumour after osteosarcomas and is about 25% of all these malignant bone tumours. It affects older people and men more than women and occurs in the central part of the skeleton. We don't know why most chondrosarcomas occur, but for a small number of people, they will arise in a pre-existing enchondroma or osteochondroma. Macroscopically, these tumours are large and bulky. They have nodules of grey-white, translucent, glistening tissue that can resemble cartilage strongly in well-differentiated tumours. What's really tricky is that ossification can occur in them as well. This can be really confusing for pathologists and is why any diagnosis must combine the pathology and the radiology. They usually grow with a broad pushing front and can infiltrate the bone marrow as well. The last primary bone tumour we're going to think about is multiple myeloma. This is a classic picture of multiple myeloma in the skull, where we have multiple lytic lesions, those dark patches, peppered throughout the skull. In these areas we have multiple myeloma, causing dissolution of the normal bone structure. So myeloma is a lymphoid neoplasm arising in the bone marrow from plasma cells, terminally differentiated B cells. There are several different diseases associated with neoplastic plasma cells. Myeloma is the most common and is characterized by involvement of the skeleton at multiple sites. If only one site is involved, we call the disease plasmacytoma. Myeloma is typically a disease of people in their 50s and 60s and causes about 1% of all cancer deaths. As well as infiltration of the bone by neoplastic cells causing pain and fracture and hypercalcemia from the dissolving bone, the tumour can also produce IgG. This is the normal job of plasma cells in the body to produce immunoglobulins. Too many of these can be toxic, and toxic light chains can be urinated away and form Bence-Jones protein, which clogs up the kidney tubules and the glomeruli, causing renal disease. In addition, they can be deposited around the body, for example in the heart, and cause amyloidosis. All this abnormal immune activity can also suppress normal humoral immunity, and therefore the patient becomes susceptible to infectious disease through decreased production of normal immunoglobulin G. So macroscopically, as illustrated on the right here, myeloma produces lucent lesions about 1 to 4 centimeters in size throughout the whole skeleton. And macroscopically, we see these as soft, red, gelatinous masses, as you can see here in the spine. So in this video, we've learned that when people say bone cancer, they often mean metastatic cancer to the bone. And there are common sites that this originates. Multiple myeloma is a disease that arises from the bone marrow, from terminally differentiated B cells, and is actually more common than osteosarcoma. Osteosarcoma is the most common matrix-producing tumour that comes from bone, the second being chondrosarcoma. Osteosarcoma is related to fast bone growth, therefore occurs in teenagers and in the elderly who have bone disease that causes bones to grow, like Paget's disease of the bone.